Welcome to the Ultimate Dentist podcast. Join us to hear success stories of various individuals and learn clinical and life hacks to help you become the ultimate dentist.
Hi everyone, I hope you are all doing great. In this series of podcasts, I am going to discuss about implant restorations. So there are specifically 6 episodes where I will be diving deep on implant restorations and what you can do and what you cannot, and how to really start restoring implants, because implants are becoming now more routine procedure. And as a general dental practitioner who are doing full mouth reconstruction, this is one of the skill you should learn, in my opinion, because you then can be in much more control. Because many time implantologists or implant surgeon who are placing implant, they may not be doing full mouth reconstruction and they may not have an idea as to how to treat implant. They might be really good implant surgeon, but when it comes to doing full mouth reconstruction, they might not understand the whole concept. So in that case, you need to be able to dive in and help those surgeons in planning, and then you can take over and execute that treatment plan and give patient the fixed teeth which they deserve, which are functional, and moreover, they last long time. So in these 6 episodes, in episode 1, I'm going to discuss about treatment planning. Episode 2, I'm going to discuss about implant impression. Episode 3, I'm going to discuss about communication with the laboratory and what you need to really tell the lab what to make, what not to do, and what to look out for. Episode number 4, I am going to discuss about how to fit this implant restoration. Episode number 6, I'm going to 5, I'm going to discuss about maintenance, and 6, we are going to discuss about troubleshooting, because once you start restoring implant, you will come across problems and how to resolve those problems. So these 6 episodes are jam packed of information, so watch out for those episodes. And these episodes are directly taken from my book. So I have taken few things from my book and I'm discussing those things. There are obviously much more. I go much more in detail in my book on introduction to implant restoration. However, it's very difficult over podcast to discuss all this, because you need really a picture, you need a photograph, and as I say, the picture paints 1,000 words. In my book, I have 320 photos, so you will be able to see much better. Whereas in the podcast is I have a limitation. So I will be doing a webinar which will be free for all of my listeners, so I can really show you what the process is and really interact with you. So if you see the link in the description, if you look at the description of this podcast, and if you see the link, you will be able to register for future webinar which I will be doing for implant restoration. When you register for that, instantly you will be able to download my comprehensive assessment ebook as well. So you will be able to start doing comprehensive assessment for those implant cases. Plus, it has a occlusal assessment in there as well. So there are lots of things in there. So watch out for that link on the description. Go below the description and check out the link and register yourself for future emails. Having said that, let's discuss about treatment planning. So first of all, before we discuss about treatment planning, we need to really understand what are the differences between implant and natural teeth. So obviously one of the main difference is that the implants do not have periodontal ligament. Natural teeth have periodontal ligament. And that's the biggest difference. And a lot of things, a lot of implications are related to the fact that implants, they're fused to bone, rather than like teeth which have periodontal ligament, which has a rich blood supply, sensory sensation as well, so you can understand and can see what's going on, rather than implants where there is not proprioception. You have osteoperception in regards to implant. You have a perception coming from bone which is not as rich as proprioception, which is from ligament, which is from nerve endings. You have, with regards to implant, you have a long junctional epithelium attached to the implant, whereas you have really hemodesmosomes and basal lamina when it comes to natural teeth. You have 12 types of connective tissue fibers attached, inserted into the natural tooth, whereas you only have two groups of fibers attached with the implant. Biomechanical designs and vascularity is also different. You have less of the vascularity around the implant than what you get around the teeth. And as I said, the proprioception is another main thing. You have a mobility which is much different than teeth. Teeth move. So if you look at the central incisor, they can move up to 100 micron, 110 micron. Whereas when you look at the implant, they don't have that much mobility. Although implant move a little bit, but they are in very small number microns because bone flex. So implant can also move, but it's still much less than the teeth. Usually, with regards to pain, you have tooth which becomes painful and you can feel the pain, whereas many times you will see that with implants patient don't feel pain. The bone gradually erodes, and patient will generally come out and say my implants loose, and it comes out from the mouth, or you see pus and everything, and then patient still not in pain. So most of the time when I see patient not in pain, of course if the infection is acute, then they can get pain. There are different complications you have when you have occlusal overload with regards to tooth versus implant. With the tooth, you see wear facets, you have abfraction, fremitus, attrition, mobility when you overload the tooth. Whereas if you overload the implant restoration, then you have porcelain fracture, implant fracture, screw fracture, abutment fracture, possible screw loosening, or you can get in bone loss or pocketing. Having said that, the biological implication of occlusal overload is quite debatable. So there are some studies says there is a biological reason. Some studies doesn't support that. But we know that the mechanical issues is definite when you have occlusal overload with implant restoration. You have when you have teeth, they are better as at checking perception or interferences. So if you have interferences around when patient closes, patients are much more aware of that than osteoperception. Of course, not every patient is aware of the interferences or non-working side contacts, but if you compare, you will have less perception with implant than the teeth. Implants are also not very good at taking non-vertical forces, again because of the mechanical properties and everything. So with regards to implant, you want more sort of a longitudinal force. With regards to movement, if you see the lateral movement, as I said, the natural teeth can move up to 56 to 108 micron, whereas the implants can only move 10 to 40 micron. You have apical movement when patient clenches. The natural teeth can sink from 25 to 100 microns, some of them, whereas the implant will only sink in maybe 3 to 5 micron, and that's mainly because of the flexion of the bone. They don't sink in, but it's just the bone flexes and you see a little bit of movement. So, and that's really important when you are checking occlusion, and that we will discuss at the time when we are discussing implant fitting appointment. You're looking at the tactile sensitivity is pretty high when you patients have a natural tooth, whereas with implant it's much low. And as I said, when you are overloading the tooth, then you will see PDL widening, fremitus, mobility, wear facets, or pain. Whereas with the implants, it's usually mechanical failures. You will see a lot of screw loosening or implant abutment fracture or porcelain fracture or some sort of a mechanical issue. And as I said, you can get bone loss, but it's debatable upon. We don't know. So considering all these things, there are 12 factors which you need to understand when you are doing treatment planning. So let's look at those 12 factors. Number one is patient expectation. And this is something I always discuss in detail when I'm teaching anyone full mouth reconstruction. You do not want to take a big case, where you don't get along with the patient, or patient doesn't get along with you, or their patient's nice but you just cannot match their expectation. And this is the time to bail out. If you're not going to do any treatment, this is the time to tell patient that I can't help you. And that's the best case scenario. The worst case scenario is you tag along it because you want to do the treatment and you want to learn and you want to practice your newly learned skill. You say yes to everyone, and come the end of the treatment, patient's not satisfied. Now you're kind of in a stuck position. You have to do anything and everything in order to make that patient happy. Now, with regards to implant, it's not that straightforward. If the implant's not in right place, there's not much we can do apart from sometimes taking the implant out, which is much more invasive. And if it's done nicely, and then putting a new implant with a bone grafting is much more traumatic, rather than, let's say, you've done an edge bonding and patient doesn't like it, you can change it quite easily. With implant, it's much more worse complication can happen. So you need to have patient on your side and need to make sure patient understands what's going on. You also need to have your implant surgeon on the side, because if you're not placing implant, then you need to treat implant. You need to then discuss with your implant surgeon to make sure it's possible, and you need to communicate with the surgeon as to what are the patient's expectations, what are your expectations, whether you want screw retain or cement retain crown. Again, we will discuss that a little bit later in the following episodes. But you need to discuss with implant surgeon what exactly you would want, and you need to, if you're not placing implant, then you need to really work closely with your implant surgeon to give the patient the best outcome. Because ultimately, if you haven't if patient's not happy because the crown's not in the right position, doesn't look nice, they're going to come to you. They can't see implant, so they're not going to go to implant surgeon and say, oh, you put the implant in the wrong position. They will always come to you and say, look, my teeth doesn't look nice, can you move it? And you say, well, the implant's not placed in the right position. But ultimately it'll be your responsibility, if you have taken this case on, to provide an aesthetic restoration. Of course, it's a joint responsibility, but when it comes to patient's mind, they will think that it's your responsibility. So that's number one factor: patient expectation and communication with the implant surgeon. The second factor is treatment alternatives. So you need to really consider alternative treatments. Implant is not always the right option for that one particular patient. I always give advice that if patients are central incisors missing, one incisor, ideally maybe Maryland bridge or some sort of adhesive resin bonded bridge is a better suited option than doing an implant for central incisor, lower central incisor, because generally you don't have to. Now, of course, if the patient is really big and you got nice space between two teeth, then yeah, go ahead and do implant. I have done implant before for central incisor for a young patients where they don't really want to show the metal showing. Nowadays you can do zirconia resin bonded bridges, but so you need to consider the options. Sometimes denture is a better option. Like, let's say if the patient's got compromised dentition. Now if I'm placing an implant, I want to make sure that the rest of the teeth can support implant as well. I don't want to have really nice implant done and then patient doesn't have any other teeth, and the teeth will start, or teeth in a good condition, and the teeth start falling out. So I always tell patient that, look, unless you're considering full mouth, sort of full arch or total extraction, for now, have a denture and see how you get on, because the other teeth may not be in a great situation, but they might be good enough to tag along and to last. So that might be one of the reason. With regards to bridge, sometime I did last year, was it, or a few months ago, 3 to 3 upper canine to canine bridge for one of the patient, because his medical condition didn't allow him to have implant and it was a bit risky. And we know that canine to canine bridge works fine. They do work. So however, if I could have placed implant, I would have placed implant in lateral positions and give patient a nice implant supported bridge. But sometimes you have to go for a bridge. However, 90% of the time, implant would be the best option for an edentulous space. But you need to make sure that you don't get biased. You need to make sure, and this is something I tell my patient, that I don't want to get biased because I do implant. I don't want to just make sure that you just you here for implant, we don't consider any other option. We need to consider all the options. Number 3, you need to assess patient's smile line. It's really, really important. Especially when the anterior teeth, but also posterior teeth. So always ask patient to grin. Make sure they move their lip up and see, like you can see how far the lip goes up, and have some jokes ready to make them smile. But generally, patients will be conservative in smiling when you're taking photographs. So you need to ask them to really fake it, and you want to see how far the lip they can lift up. If they can see, if patient has a very high lip line, then it's a high risk case, obviously. You need to assess patients. Factor number 4 is patient's oral hygiene and general periodontal health. Now, I must admit that I have, in the beginning, what I used to do is send patient for hygienist. Patient had a cleaning done, and I'll place an implant. However, over the time, what I've realized is sometimes patient who doesn't have good oral hygiene, there is a reason behind it. So unless you break that habit, you will give patient a nice implant and they won't be able to clean that either. So you need to make sure that your patient is able to clean their implant, and the best way is to get them on hygiene regime and get them into habit of seeing hygienists regularly. Number 5 is adjacent teeth. This is something we don't really discuss much, or we don't assess much. Not even your technician will give you a good idea. I mean, I used to have a technician which I used in Italy, and he used to really give me all the indication, because many time you will see, like if you're doing a central incisor restoration, you may find better result if you are maybe doing a little bit composite bonding on either side of the teeth to close the space, to get the space distribution really well. And this is something you may not be able to assess straight away unless if you have models in hand and you're doing the work. So because I do wax up, I used to do wax up by myself until 9 months, a year ago. And many time while I'm doing the wax up, I realize, okay, I want to do this, I want to add this on this tooth, and it will look better. But if most of you won't be doing wax up by yourself, so you are relying on your technician to tell you. But if there is any obvious thing which you can improve by adjusting either side of the teeth, either by adding, or sometime, if you have, let's say, lower right 6 has come out and lower right 7 has got this overhang amalgam, or it's got fractured amalgam in the mesial aspect, it's better to change the restoration. If the contact points are not nice, then it's better to just make them nice and flat so that technician can close the space properly. So that's something you need to assess. Number 6 is advising patient on secondary or complementary treatment, such as teeth whitening, cosmetic treatment, orthodontic treatment, or full mouth reconstruction. Teeth whitening is one of the most commonest thing. You need to make sure you discuss this with patient. You don't want to have patient going through all this and then say, oh, I wish I had whiter teeth. So teeth whitening is a must, in my opinion. You need to then discuss, if you're doing implant, so discussion of teeth whitening is a must. I mean, if patient doesn't want teeth whitening, then that's fine, but you need to discuss it. You record it in your records, because let's say you've done implant restoration and patient's like, oh, I want to do teeth whitening. Now changing the implant restoration is much more expensive than just changing a filling. You need to discuss about the cosmetic treatment. If patient wants edge bonding, veneers, something like that. Before you do that, you need to discuss ortho, which is much less discussed, in my opinion. I would say probably 75% of the patient who I see would benefit from some sort of ortho. Not all of them would go ahead with it, but you at least need to have a discussion. You need to discuss about full mouth reconstruction, because if let's say you're raising OVD, let's say you've done implant on lower right 6, now you're raising OVD, the implant restoration will have to be changed. So you need to make patient aware. If patient doesn't want the treatment, then it's up to you and patient to decide. But you definitely need to let the patient know, if patient needs full mouth reconstruction, that look, if you don't have this done now, and if you decide to have this done later, your implant crown will have to be changed, and that will be obviously additional fees. So you need to let the patient know. Number 7 is restorative space. So make sure that you have enough mesiodistal and occlusal, interocclusal restorative space for the implant. Number 8 is hard and soft tissue. You may not be able to assess that, and this is where your implant surgeon will be able to help you with a CT scan and clinical assessment, whether the defect is soft tissue defect, hard tissue defect. How can we manage it? Generally, the defect is going to be composite, which means hard and soft tissue defect. Generally, you don't have just one or the other. Many times you can place the implant in the bone without doing bone grafting, and just do soft tissue grafting. But if there is a defect, generally it's both ways. So you have a little bit soft tissue, a little bit hard tissue defect. Number 9 is number of implants. And what that means is that, let's say you have upper right 4 and 5 missing, and patient wants implant. Now, sometime you can put 2 implants in upper right 4 and 5 region. However, sometimes you don't have space to put 2 implants without compromising inter-implant distance. You want 1.5 millimeter distance between tooth and the implant. You want 3 millimeter distance between 2 implants. So make sure that you have enough space for 2 implants to be placed. And if you think you don't have enough space, then it could be 1 implant and a cantilever bridge. Now, this is something you may not be able to decide. Your implant surgeon might do a digital planning and then decide. So when you are discussing this with patient, you need to really give patient an idea. Generally, as a standpoint, I will give patient an estimate with 2 implants, but just say that if it's possible, we might do cantilever. And many times patient would come and say, oh, can you not just place 1 implant and do 2 teeth, because obviously it's cheaper. But I always tell patient that, look, yes, you'll probably save 1,000, 1,500, whatever pounds. It's just not worth it. If you can place 2 implants, it's best to place 2 implants for support. Obviously, if you're doing full arch dentistry, then that's completely different. You can get away with 4 to 6 implants in 1 arch and restore the full arch. However, if you're doing full arch, generally it's 8 implant on the top and 6 implant on the lower arch. But again, you can get away with 4 implant on either arch. But that's different. So as I said, your surgeon might be able to make that decision. But my plan is generally I do not do cantilever unless there is not enough space for me to place 2 implant. Number 10 is how you're going to provisionalize it. Now, today I saw a patient who had upper left 1 crown fractured. It's a post and co-crown, periapical lesion, needs to come out. Now, I need to already start thinking, okay, how am I going to provisionalize it? Am I going to leave it as it is? Obviously, it's not socially acceptable. Are you going to give patient a denture? The problem with the denture is if he needs a bone grafting in future, I generally don't want the patient to wear denture, because denture will rub against that. Even if you just keep it off the ridge, it will still give pressure from the palatal area. So you don't want denture for those cases. Then the option is Essex retainer with a tooth, like you do Invisalign, and if patient's missing tooth, then you do the tooth. So that's one of the option. Or you can do resin bonded bridges. The problem with Essex retainer is that patient will have to take the retainer out in order to eat, and again, that's not socially acceptable. So patient can't eat with the Essex retainer in. The other option is resin bonded bridges, where patient doesn't have to take things out, but then you're not going to stick resin bonded bridge with panavia. You're going to use GIC to stick resin bonded bridges, and then that leads to it may come out prematurely, like before you want. It might come out, so that can lead to some emergency appointments. Patient might not be happy. um, Plus, when you do resin bonded bridges, you don't want to really grind either side of the teeth to create space, so you're going to leave that in high, and that will change patient's occlusion a little bit. And it may be that it will settle after you take it out, but it may not settle. So that's something you need to be aware of. The other option is, let's say if you are replacing upper left one and upper left 2 and upper right one, they both are crowned, which needs changing. So in that case, you can take those old crowns out and give patient a fixed bridge temporary from upper left 2 to upper right 1 to replace upper left 1. And that's temporary. So every time patient comes in, you take it out, you cement it with Tembon or temporary cement material, and you take it out in and out every time patient comes in, do your stuff, and then put it back in again. And that's how patient can get fixed bridge. But this only works in very minor cases. There are not that many patients who have crowns which needs changing. So that's something you need to be aware of. So these are the 5 options: nothing, denture, Essex retainer, resin bonded bridges, or using either side of the teeth for bridge. Number 11 is occlusion. You need to really be able to visualize what the final occlusal scheme is going to look like. Whether you're going to use canine guidance, group function, protrusive guidance, what are you going to use? Which teeth are you going to use? Are you going to use implant for guidance? Are you going to involve implant in any guidance? Ideally, if it's possible to avoid implants, then it's best. Of course, if you remember, we are going to, in this 6th episode, we are going to discuss about single implant restoration, or at the max, maybe 3-unit bridge. So many cases you will be able to avoid guidance, but there are cases which you can't avoid guidance. So you need to understand. And number 12 is diagnostic wax up. So once you know what kind of guidance you want, you can ask technician to do diagnostic wax up based on that. And that will then lead to surgical guide, and then that will help surgeon in placing implant. So these are the 12 factors: patient expectation, treatment alternatives you need to discuss, denture, bridge, or no treatment, smile line, oral hygiene, adjacent teeth if there is anything you need to do, complementary treatment, whitening, cosmetic treatment, ortho, full mouth reconstruction. You need to assess restorative space. You need to assess hard and soft tissue. You need to assess how many implants patient will need. You need to assess how to provisionalize, or whether to provisionalize the edentulous space at all. And you need to assess occlusion and do diagnostic waxer. So I hope this episode has been helpful and you understand the implant planning process. As I said, I've discussed much more in detail, and I will be discussing this more in detail with the photographs and everything when I do the webinar. So register yourself for the webinar, and I will see you in the next episode.